got a chance to talk to them then. And then we had them come and give us a demonstration. So my attitude initially was, like many physicians, is this just another gimmick they're trying to sell and make money on? But we started to look at it more intensely, and we started to get one and use it in the office. And so I'm going to share with you today a little bit about shockwave. Now, what is happening here? This is okay. Now it should work. Yeah. Okay. So we're going to talk first about the shockwave and then a little bit about electromagnetic transcranial stimulation. So, pressure wave. We call a pressure wave. Our patients seem to like that better than shockwave, because the shockwave scares them a little bit. They think they're going to get electrocuted, and it's not. So we call it a pressure wave. It's a non-invasive treatment for acute and chronic musculoskeletal pain. We've been using it. I used to do a lot of prolotherapy that they're teaching in the other workshop next door. Since we got this machine, I haven't injected a needle in several months, because the shockwave is doing what the prolotherapy needle used to do. And what we've been doing is combining the shockwave and then adding the laser. And it's a great combination. So we know shockwave or acoustic waves, initially sound energy. Dr. Weber just spoke about light energy. This is sound energy. And so we know it was used in urology for lithotripsy. That's outdated now, but it's been used for many years. So it's not a new technology. What it does do, though, is it stimulates cells to heal, and I'll show you in a minute how that happens. But it provides a mechanical stimulus. It disrupts tissue. So it disrupts fibrous tissue, it disrupts the fascia, it disrupts scar tissue, and then it results in causing a lot of neovascularization, and it draws the chemicals for healing to its area. So it is setting up the body to accept the energy change from the laser and get a healing process going. So we have to thank Dr. Halassa for interjecting that last year, because we learned a lot from it and it's really helping our patients. So it reduces or eliminates pain, it increases circulation and metabolism, it stimulates the neovascularization, it stimulates tissue and bone growth, it brings the biological mechanical transduction in, and it dissolves calcium deposits. Now, what are these responses? Well, bone morphogenic proteins, they're growth factors. NOS is nitric oxide synthases. It's a family of enzymes. They're cellular signaling molecules. Vascular endothelial growth factor is also, that's been mentioned earlier. It's also working on vascular permeability. And the proliferating cell nuclear antigen is a DNA clamp. It literally will go around a protein, and it acts like a clamp around the protein to draw other proteins to it. Those four things have been shown in the studies to be the result of what happens when we do this sound wave energy. Okay? So when we're using a pressure wave, we're creating a biological response of those factors that I just talked about. And they all come in, they improve the blood supply, and they get tissue regeneration going. They also repair bone. There was a lady that had a huge calcium deposit on her shoulder. And she had some sound wave treatment, and it was gone, completely resolved without anything else. Here's a slide that just demonstrates the angiogenesis compared to control. You can see the difference. And in those factors that we just talked about, how much more of them are happening compared to the control. So it's not a gimmick. It is something that's really working. The hard part is to get people to understand medically that this is not just gimmickry. The laser is not gimmickry. Active acupuncture is not gimmickry. All the stuff we're talking about today is not gimmickry. The food is not gimmickry. But sometimes it's hard to get people to open their eyes and ears and hear that there's a different thing going on that may actually work. So we changed cell membrane permeability. We release neurotransmitters. It's got an antibacterial effect. It releases nitric oxide. It releases the growth factors we talked about. It induces vessel growth, and it causes stem cell migration and differentiation. This we've seen, but you can see the change in the vascularization. These are the conditions. They look very similar to what we just saw about the laser, don't they? Okay? Excellent conditions to be treated with this technology.
I would think bone spur should be up there.
Pardon me?
Bone spur.
Yeah.
That's plantar fasciitis.
Yeah.
Well, plantar fasciitis is not the same.
Yeah.
Wow.
In fact, we are treating someone already for that, and I have another person coming in. He's going to start treatment next week.
How often do you treat?
Pardon me?
How often do you treat?
Once a week with this. The laser more often, but once a week with the pressure wave per area. Because we have another patient, we have a patient with complex regional pain syndrome that we're treating, and she's got now a lot of myofascial stuff secondary to the CRPS. The CRPS we've pretty much fixed. She doesn't have her allodynia anymore, but she's got huge myofascial problems secondary to having not used that extremity for a long time, and it is still hypersensitive and hyperalgesic, so it's hard to get movement. And I just started treating her, but you'll see when we want to use the gun has a little viewpoint, a little screen, and it shows you how much pressure to apply to get to a therapeutic level. It shows the increase in intensity that we're using. So everything is listed and documented as to what we're doing with it. Most people were trying to get up between 2 and 3 bars on the strength of the intensity of the pulses. With that particular lady, because of the hyperalgesia, I'm going about 1.3 because that's all she can tolerate. And we're barely able to push pressure into her, but it does work. She feels a lot better. Okay, here's what's been happening. The AMA Journal, 91% improvement for shoulder pain, 90% success rate for heel pain, 77% improvement for elbow pain, Achilles pain, 8 times more effective for hamstring pain than regular physiotherapy and chiropractic treatment. So if we think about what Dr. Davis spoke about this morning, we're having an effect, and what Dr. Bryan spoke about, we're having an effect on the fascia, obviously, right? Because this thing's like a gun. It's pulsing. It's boom, 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 boom. Depending on the strength with which you do it, it depends on how deep you're going to go and how you're going to penetrate. It also comes with different heads, so you get a different dispersion of the sound wave depending on what you need to do with it at that particular time. But we are disrupting that fascia, okay? And one of the things that Carol pointed out, with John Barnes, is a very gentle release of the fascia. This thing is kicking it, and it kicks it, and it gets it loosened up, and it gets all those changes happening that Dr. Bryan talked about, and Dr. Halassa will also talk about how we can get more nitric oxide and redox going with these areas. Success outcomes, Mangone and I think they did a study. They looked at rotator cuff calcific tendinosis. The pain scores went from 5 to 1 after treatment. The active range of motion improved, and they had better results after 3 months. The other interesting thing about this technology is the patients will report that they feel good when they're done with the treatment. It hurts a little bit while you're doing the treatment. They're going to be sore for a couple days, but then they heal and then they get better. Time keeps going, because the process that we're talking about, we're talking about changing fascia, bringing in stem cells, recreating new growth, making things heal, takes time. And so patients will report to you that they feel better a month later, or 3 months later, they're even better than they were at a month. And that's one of the beautiful things about it. So that's exactly what happened with this when they did the rotator cuff calcifications. The results were better after 3 months than they were right away, even though you do get improvement right away. Okay, another study was done on plantar fascia. It was a retrospective study. They did an average pain level before treatment was 6.9, reduced down to 3.6 1 month after, and 2.2 and 1 after 3 months and 1 year. So even a year later, the results are better. So what we're doing is we're setting up a healing process that allows the body to heal itself the way it should, that it couldn't do on its own. Another one on an orthopedic condition was a systemic review of studies listed in a pediatric orthopedic journal, and they did an extracorporeal shockwave therapy, which was an effective and safe non-invasive treatment for tendon and other pathologies of the musculoskeletal system. But is it really the tendon or is it the fascia? Okay. I think we have to keep that in mind with all the stuff that we're looking at. Insurance company Aetna considers it medically necessary for calcific tendinopathy, but unfortunately for them, they require that the tendinopathy has to be a centimeter or greater in size before they'll say it's necessary. I mean, this is the way insurance works, okay? Anything else they consider experimental at this point in time, but they are willing
think
to pay
about
for that.
just destroying the calcium.
Yeah.
deposit.
So they need to accumulate more data. What's interesting is next month, July 2017, they're going to do their next policy review, and hopefully they'll add some other things that may be covered. This was the shoulder before and after. Okay, a 44-year-old man, 4 weeks. That's a month after treatment.
One treatment a week?
Pardon me?
One treatment a week?
One treatment a week.
Excuse me, do you have any, like a clavicle fracture that you can talk about?
I don't. Not at this point. I haven't had it long enough. Chuck, do you know of any experience with clavicle fractures?
No, I do not,
Okay.
off the top of my
No.
head.
Usually heal
Okay.
around.
3 to 5 treatments, 7 days apart each, 3,000 to 5,000 pulses per treatment. Again, it counts the pulses and it lets you know how many you've done. You can't do too many, you don't want to do too many. The patient has to let us know. What we do is when we start treating a patient, I say, okay, we're gonna start now. We start low, and I'm going to increase the intensity as we go along. Let me know if you get to about a 7 or 8 level pain. Let me know. Otherwise, it's okay. And that's what they do. So we do need their feedback during the treatment. This is just a viewpoint. This is the little viewing screen. You get it. It's in the handle of the gun, and the advantages are it's non-invasive. You don't have an infection risk. You don't need anesthesia. There's no scarring. You can treat bilaterally. One of our staff members is able to do this as well as I do, which is different. She does the laser also if it's superficial. I have to do the IV or intra-articular. Okay, so potential adverse reactions, you can get some swelling, reddening, or a hematoma. You can get some petechiae. It does hurt somewhat. You can get skin lesions if they've had cortisone injections. So you want to wait about 6 weeks after a cortisone injection before you do this. And the side effects generally are gone in 5 to 10 days. There are some contraindications. Certainly you don't want to pump the lungs because you can beat them up too much and people won't be able to breathe well. Heart reactions can occur. So again, we need the patient's feedback on how they're feeling We should not do more than 6,000 pulses at a session, and most of the time we are good with 3,000. Sometimes we go to 6,000 depending on the person. It's contraindicated here, but these are relative contraindications. Obviously, if I'm going to be banging away at some tissue and the person's on an anticoagulant, I have to be careful not to hit a major vessel and start them bleeding, because they're going to keep bleeding, so we don't want to do that. But it's not an absolute contraindication, and I think that's important. Pregnancy, certainly we don't want to do that. Realize that, this sound wave is going through things, okay? So it'll go wherever it hits. And again, the cortisone therapy, if they had it within 6 weeks.
Will you do more than one area per session?
No, we don't. We do one area at a time. We may do an upper back, and I'll do both sides, okay, in one session. But I don't do an upper back and a low back all at the same time.
You'll do a shoulder and a knee.
No, I wouldn't do that.
Diminishes the effect.
I wouldn't do that. Yeah, I wouldn't do that. You're trying to draw the stem cells to it.
Okay.
Okay, so you don't want to spread them all over the body. You want to concentrate them.
Okay.
Yeah.
You also should consider with the shock waves, you also stimulate acupuncture points. That's
Yes.
something what we also have
Sure.
to consider. There were nice studies in Germany about shockwave acupuncture. So this, the acupressure also, no, is a way
Right.
to stimulate acupuncture points. This is an amazing method also to do it on acupuncture points.
Yeah.
No? Maybe locally, but maybe also some. And we are using this also together with light successfully, and we use also the shock waves to stimulate the photosensitizers as zonosensitizers
Wow.
with shockwave. That's another option to use it in photodynamic or sonodynamic cancer therapy. It's amazing, this
Yeah.
kind of therapy.
I hope Dr. Weber tomorrow, or maybe today at the end, we can ask him to speak a little bit about the oncology work they're doing. We're also going to be doing a study with them for dementia. There was a case presented to us, a study presented to us at a meeting in San Diego earlier this year, where they did some red and infrared laser therapy on dementia, mild to moderate dementia patients, and the mini-mental status improved 3 times better than it did with Aricept.
We made a
3
special.
times
We made a
better.
special helmet. You will
Now,
get this in
what-
some weeks.
Yeah, what was interesting was, after they stopped the study, they looked at the patient a month later, and the mini-mental status was falling down again. So what it means is, this is something the patient needs to be able to do at home on a regular basis. It's a 20-minute treatment, and that's all they need, but no Aricept and no side effects. We're going to be setting up a study with Dr. Weber's wrist watch, because we can hook a helmet into that. We can do the acupuncture in the wrist, we can do the arteries in the wrist, and we can do the head at the same time, and intranasally. So we're going to take a look and see what happens with that. Here is a case that we did. A 56-year-old woman had a low back injury. She had painful sacral spinous ligaments from S1 to S4, painful right gluteal muscle origins. She had painful right SI ligament, painful soft tissue between L5 and S1. We treated her with the pressure wave at the sacrum, followed by a large shower head with red and infrared. In one treatment, that pain went away. One treatment, a week later, 2 weeks later, she had no more pain in that area. She did have some remaining pain at the L5, S1 soft tissue area. That's a little harder to get at. It's the iliolumbar ligament, and it's a little harder to get at. So we're still working on that part. But one treatment only is all it took. Another case, we had a 3-year-long thoracic trigger point in the lower trap on one side. One treatment with the pressure wave, followed by a large shower head with red and infrared. 15 minutes of laser after the pressure wave. No pain or tenderness at 2-week follow-up. This was a trigger point that was really hard to get at, because it was a very fibrous trigger point, and it was long. It was probably 1.5 inches to almost 2 inches long. So I can needle a trigger point where it's over a rib, but I can't stick a needle into the trigger point in between ribs, or I'm going to give them a pneumothorax. Once we got the pressure wave, I can whack that whole trigger point, and it just took one session, and that's gone. So it really worked very well. Okay, transcranial magnetic stimulation's been around a while. It's been used a lot more in psychiatry than it has been in pain. But I thought we should at least address the issue because you're going to hear about it. Some people are saying it's wonderful stuff and other people are not so convinced about it. The same thing in psych. They've used it a lot for trying to treat depression. And in some depressions it helps, and in a lot of them it doesn't help. So I thought we should take a look at that. They looked at repetitive transcranial magnetic stimulation in chronic pain. They reviewed the literature in 2015, and here's what they found. They found 33 randomized trials. Some studies reported significant pain relief, especially high-frequency stimulation over the primary motor cortex, performed in consecutive sessions. The pain relief was frequently greater than 30% compared with control. So that's not real great. 30% improvement in pain over control. You know, placebo is 30%. So is that really something good or not? I don't know. That's what they found when they reviewed the literature. It had been tried on neuropathic pain, fibromyalgia, complex regional pain syndrome, but most published studies, only a few of them performed repetitive sessions. So again, if you're not, maybe they didn't do enough to get a good result. I don't know.
Well, I think it's better not to put it on the lesion, put it around the lesion, the healthy tissue, to trigger the physiological free radicals, the good ROS, and that leads to stimulation of antioxidant, anti-inflammatory, and
Yeah, but
anti-pathogenic.
this is transcranial. This is
I'm
this is
talking
over the motor cortex.
Oh yeah, I'm talking
Yeah,
about.
Yeah, not the body, motor
Alright.
cortex. Okay. All right, so it has potential utility in the management of chronic pain, but the studies using maintenance sessions and assessing the effects on different aspects of chronic pain are needed to provide a more solid basis. So again, with chronic pain, we don't have real good data yet to say whether it helps or not.
I know from...
Wasserman reviewed the risk and safety. The biggest problem with transcranial magnetic stimulation is you might induce seizures. So that is something you have to be aware of.
I know from Professor Paulus, you know, I showed the study here from Göttingen Neurophysiology about this transcranial laser therapy. They also work with transmagnetic therapy and also electric stimulation,
Yeah.
and the results are quite similar. No?
Yeah.
You have this is the neuroplasticity of the brain, so you can reduce the excitability in a very similar way.
Yeah.
Yeah, so maybe you can even combine it together in chronic pain.
And the same thing happened with the electrical stimulation when they were doing that for depression as well many years ago.
Yeah.
And the problem you run into is you have to do a low-level electrical stimulation enough to work on the depression but not cause a seizure, because that's how we used to do shock therapy, right? Electroshock therapy was causing an electrical stimulation that made a seizure happen. Okay. So, contraindications for it is metallic devices, pacers, anything that any medication that can lower seizure threshold, such as tricyclics, which again, since they've been doing a lot of this with depression, you have to wonder, because most of the patients are going to come to them on some kind of an antidepressant, and most antidepressants lower seizure threshold. So it is something to be cautious about. There is not a lot of literature in chronic pain yet. I don't know if there will be, because I don't know how much research is going on, but it is something you should know about in case you hear about it in the literature. Okay, so now we're going to move on to the fellow who is full of good things to tell us, and Dr. Halassa. I had asked him, since Dr. Bryan gave the foundation of nitric oxide and what goes on, I've asked Dr. Halassa to focus his talk on what we can do to improve nitric oxide. Okay? Good. Thank you.
He told me his name is the Emperor Marcus Aurelius.
Huh?
That's his real name. So he's changed his name.
No,
Marcus
I said Marcus originally from my native,
Well, that's why I'm saying you change
the
the name
gladiator one.
from Falahuddin to Marcus.
Okay.
You change the name from Falahuddin to Marcus. If I know that, you should have changed the name to Marcus, whatever your last name is. I can't pronounce it.
borrow it, but you have to give me back.
There you go.
It's more appropriate for you.
What is this? It's not recognized as a device.
Is mine working?
And I get it down first. It's looking at the website.
Really?
Okay, for 30 minutes.
There it is, yeah. I just heard it.
What treatment is this supposed to do?
Oh, really?
Yeah, yeah, we're a little over, so. No.
We'll find out tomorrow, how much maybe today.
Your roof is here? Yeah.
Here it is. Got it.
Yeah, yeah. That's what it's for.
Slideshow for the beginning. Slideshow. Here.
Doesn't work?
Yeah?
Yeah.
Okay, good.
Okay.
Now, you're all set.
Great. So my name is Dr. Hadas. I'm the founder and author of Nitromedicine. And so I'm a team of doctors. Dr. Weber, he's here. Michael. Dr. Norm Shelley, he's a retired neurosurgeon. He's the first surgeon who placed the spinal cord stimulator in the back. We have Dr. Garish, who's here, right, somewhere. And Dr. Michael Hamblin, he's a Harvard medical professor. He's a pioneer in photo medicine. And Dr. Albert Ray, he's a pioneer in integrative medicine. And I think he's doing very good in cognitive therapy as well. So what is nitromedicine? It's a new specialty that focuses on managing chronic disease or diseases and restoring the nitroredox balance. And I'm trying to emphasize on a very important concept before we go into the whole detail here about redox potential versus pH. It's very important that our doctors need to take the redox potential and consider it as a very important concept to translate all kinds of alternative medicine, whether it is photo or electro or sono, that they work through modulation or restoring the redox potential homeostasis. And I know redox potential concept is not yet in the medical books. We have the pH, yes it is, which is acidic and alkaline, and it does affect the acute conditions, the ER conditions, and we are very working on, when we work on restoring it as part of managing of all these acute conditions. But in chronic condition, really the player here is redox potential. And what's the difference between redox potential and hydrogen potential, which is the pH? Redox potential is the tendency of the substance to attract electrons versus hydrogen potential, which is pH, which is the tendency of the substance to attract protons. And so I think when we are going through the slides, we will have more understanding about redox potential and how it's controlling the cell cycle, the genetics, the apoptosis, the anti-apoptotic genes, the antioxidants, circadian rhythm, cardiac rhythm. All of this, you will see, it's all regulated by the redox potential. Now, we mentioned that by restoring the nitroredox balance, we can manage all kinds of chronic diseases, whether it is degenerative, autoimmune, chronic inflammatory, chronic infectious, pain conditions. And why? Because all of them, they share a common thing, which is increase in the pathological free radical and decrease in the nitroxide bioavailability. I call this nitroredox imbalance. That is what they share, right? Whether it is the disease that affects the heart, the myocardial infarction, angina, or the disease that affects the skin, psoriasis, dermatitis, rosacea, whether it's affecting the joints, rheumatoid arthritis, osteoarthritis, whether it's affecting the lung, asthma, or COPD, whether it's affecting the immune system, the brain, Alzheimer, Parkinson, autism, migraine, all of them, they share a common thing, which is an increase in the pathological free radicals and decrease in the nitric oxide bioavailability. So, how we manage these diseases? By restoring the nitric redox balance. We can slow the progression of these diseases by just restoring the nitric redox balance. In fact, some of the conditions we can completely resolve it and manage it, like complex regional pain syndrome. It's completely resolved and managed by photomedicine and nitric compounding, which contains thiols and polyphenols and nitric oxide donors. And so other diseases, we can at least slow the progression of it, manage the symptoms of it, and all the therapies that we talked about, whether it is regenerative or integrative or functional, ultimate mechanism is restoring the nitric redox balance. So how we diagnose oxidative stress-related disease, and that's what we call those conditions because they're sharing a common thing, which is high pathological free radicals, we call them oxidative stress-related disease. So how we diagnose oxidative stress-related disease? We find out that with patients with oxidative stress-related diseases with high pathological free radicals, it causes shortening of the telomeres, right, by oxidation. It also can affect autonomic nervous system. Autonomic nervous system is very sensitive to the pathological free radicals. High pathological free radical, low nitric oxide, cause sympathetic overactivities. So what keeps the check on the sympathetic activity? Nitric oxide. Nitric oxide does inhibit the sympathetic overactivity or keeps it down, puts the checks on it. So when you have high pathological free radicals and low nitric oxide, what would happen? You would have sympathetic overactivities. Sympathetic overactivities cause stimulation of a NOx enzyme, and NOx enzyme cause release of the free radical or produce free radicals, which you will end up with that vicious circle, right? Well, free radicals will consume the nitric oxide, causing sympathetic overactivities, and sympathetic overactivities cause stimulation of NOx, NOx cause generation of free radicals. So you end up with that vicious circle. So we find out that autonomic nervous system are very sensitive to the pathological free radicals. In fact, the high pathological free radical can cause destruction even for those unmyelinated nerves because they are very sensitive and leads to autonomic dysautonomia. So we can use the ANS testing to diagnose the nitric redox imbalance or the oxidative stress-related disease. Also, we can use the endothelial function test. Did you hear about the endothelial function test, right? Endothelium that lines the blood vessels are very sensitive to the free radicals. And if you have high pathological free radicals, you will have endothelial dysfunction, and you can test it by endothelial function test. So if you have abnormal endothelial function test, that means you have abnormal nitric redox balance or nitric redox imbalance. What that means is because there is underlying chronic oxidative stress-related disease, and all those diseases can lead to this. So we can use this diagnostic test to diagnose, to monitor the efficacy of the treatment, and also to monitor the progression of these diseases. So how we manage oxidative stress-related disease? We manage it by using nitric redox modulators. Those are the ones who can restore the nitric redox balance. Whether it is biological, stem cells, plasma, rich platelets, hear about probiotics. And we know that the stem cells, the plasma-rich platelets, they are rich with thiols and nitric oxide, and growth factors gene, and cytokines, and redox enzymes, and they can restore the nitric redox balance, right? Stem cells, not necessarily will give you that replacement effect, but it can give you a trophic effect due to the contents of those stem cells in PRP. The other way we can restore the nitric redox chemically using thiols, which is glutathione, lipoic acid, nitric oxide donor, polyphenols, ozone, hydrogen, carbon dioxide, 6-hormone, antioxidant enzymes, cytokines, vitamins, and detoxifications. The third one, which is the energy nitric redox modulators, which I think we just spoke about it, light therapy, sonotherapy, electromagnetic therapy, all of them, they help in restoring the nitric redox balance. And then we have the psychotherapy, nitric redox balance, which is cognitive therapy, holistic therapy, yoga, spiritual. And how that happens, especially for psychotherapy, we know that if you are able to improve the mood by cognitive therapy, the sympathetic tone goes down. If your sympathetic goes down, what's happened? Your free radicals goes down, right? Because sympathetic is a pro-oxidant, parasympathetic is antioxidant. Parasympathetic is anti-inflammatory, sympathetic is an inflammatory arm. So if you're able to balance the autonomic nervous system by the cognitive therapy, it's part of the management of the of the oxidative stress. Energy therapy that we saw, all of them, they work with this common thing. They increase the physiological free radical level. They cause a spark in the physiological free radical, then that will cause a stimulation of antioxidant genes, anti-inflammatory, anti-apoptotic genes. That's why Dr. Albert, he said, the effect will take days and weeks because you're working on increasing the expression of the genes of anti-inflammatory, antioxidant, anti-apoptotics. You're not working on scavenging the free radicals. It's not like giving aspirin to block the COX. You're working on stimulation of epigenetics now. And that's the way we can relay our approach to the mainstream doctors. Mainstream doctors, what they want? They want to know how it works. What's the mechanism of action? They accept aspirin because it blocks the COX enzyme. So how acupuncture works? Acupuncture, when you are putting your needle, you are causing tear and some sort of inflammation. I don't want to say inflammation because a lot of doctors, especially the mainstream doctors, think about inflammation as dysfunction. Oh, you're giving inflammation patient. No. It's actually increasing a spark of the physiological level of free radicals, which stimulates the anti-inflammatory genes, the antioxidant, the anti-apoptotic. That's how acupuncture. And here, very important, that acupuncture, prolotherapy, ozone, their effect is on the healthy tissue, mainly, not the pathological tissue. So when you do acupuncture, you don't need to inject your needle into the pathological area, but actually it may aggravate the whole thing. You just need to do it on the healthy tissue, including the waves. But light therapy is a little bit different. Light therapy can work in both ways. It buffers the redox. You can also put it on the lesion and decrease the pathological free radicals. Because those excited electrons from the light therapy, they will neutralize the free radicals. The excited electrons from the healthy tissues, they will be taken by the oxygen and cause an increase in the physiological free radicals and stimulate the antioxidant, anti-inflammatory, anti-apoptotic genes. So light therapy has double effect. It can affect on the lesion, put it on the lesion, it works. You put it in the healthy tissue, it works. That's why we're giving it for the horse races, for even human races, to increase their endurance, their ATP productions, to buffer their redox, to increase their growth factors because of their effect on the healthy tissue. Electrotherapy can also do the same like light therapy, especially the electrons. The microcurrent, not the high one, the microcurrent therapy does neutralize the free radicals, so you can put it on the negative charge, you put it on the lesion, it's okay, because it will neutralize the free radicals and buffer the redox. So, all these therapies that we are talking about, and we are preaching and trying to communicate with the mainstream doctors, which is the integrative, holistic, acupuncture, functional, regenerative, physical therapy, they all work ultimately by restoring the nitroredox balance. By restoring something is called redox potential homeostasis. Now, the mainstream doctor knows about restoring the pH, the hydrogen potential. But few of us knows about the importance of restoring the redox potential. And in chronic diseases, we fail to manage chronic diseases because lack of understanding of the importance of the redox potential and the pathogenesis of all chronic diseases. Once we understand the redox potential, which is a lot of research out there, we can say thousands, we need to translate them into clinic. And of course, the big pharma have no interest to do that because they cannot contain it, they cannot patent it. Although they try to do it. But, and we're going to see it then when we manage Parkinson's disease, you will see they're trying to do it, but they find out they fail because they cannot contain one drug, and you cannot manage redox potential with one drug, then they kind of dismiss it and move on with their big pharma products. Let's go and give an example of one of the oxidative stress-related disease that affect the nerve, which is a degenerative disease. It's called Parkinson's disease. And of course, all kinds of neurodegenerative disease does have some sort of similar mechanism. They have the sort of proteinopathy problem with recycling the waste, which is the synuclein, amyloid, but the location is different here. In Parkinson's disease, as you know, it is a chronic, debilitating, neurodegenerative movement disorder characterized by progressive degeneration of a dopaminergic neuron in the substantia nigra region in the human brain. Oxidative stress plays an important role in the degeneration of dopaminergic neurons in Parkinson's disease, disruption in the physiological maintenance of the redox potential in the neuron, induced apoptotic genes and cell death, To date, oxidative stress is well accepted concept in the etiology and the progression of Parkinson's disease. A number of sources and mechanisms for generation of reactive species are recognized, including the metabolism of dopamine itself, mitochondrial dysfunction, toxins, neuroinflammatory cells, and aging, in addition to Parkinson's disease, causing gene products including DG1, PENG, PARC, alpha-synuclein, and LRRK2, which causes mitochondrial dysfunction, leading to leakage of the pathological free radical and susceptibility to oxidative stress. Therefore, our therapeutic protocols are targeted against suppressing and alleviating the oxidative stress-induced cellular damage and increase the dopamine bioavailability. And here is the whole mechanism of Parkinson's disease. I'm going to break it down, make it simple and easy, right? So, we find out that Parkinson's symptoms manifest after 50 to 70% of degeneration of the dopaminergic neurons. Then it manifests, right? What will happen to the rest of the dopaminergic neurons? They will start, continue overproducing dopamine, trying to replenish the deficiency, but it's not enough to produce that enough of inhibitory signals needed.
I'm glad you put genetic error on the top.
Right. Needed inhibitory signals needed to block the indirect pathway, indirect motor pathway. I think Dr. Will is a neurologist here. He knows about the direct and indirect. When we're trying to flex the forearm at the elbow, right? There is a motor signal that goes the direct pathway to the biceps, right? At the same time, there's motor signals that goes to the triceps. You need to inhibit the tricep to allow that bicep to go that flexion, right? So if you don't have the inhibitory factor or enough dopamine to inhibit the indirect pathway, what will happen? You get that shaky, freezing movement, right? And slow movement, which is the symptoms of the Parkinson's disease. So, what is the cause of Parkinson's disease? Most of it is idiopathic. Around more than 95% is idiopathic. Less than 5% are toxins or combination of both. Those idiopathic, it's genetic errors, mutations. Some of the genetic errors are recognized, right? They are the synuclein, the PENG, the PARC, and DJ1, and they all cause mitochondrial dysfunction. Let's talk about synuclein. I'm very interested in alpha-synuclein because it's all about disruption of the homeostasis of the redox potential. And starting with synuclein, it's a cytoplasm protein that involved in dopamine vesicle exocytosis, recycling, storage, and compartmentalization. That's the synuclein protein function is. So if you have mutated synuclein, what happened to that mutated synuclein? They aggregate and they become protofibril synuclein, alpha protofibril synuclein. Alpha protofibril synuclein, they interfere with the normal synuclein physiological function. They stick on the synaptic vesicles. Normally, the synuclein stick with the synaptic vesicle to cause exocytosis. But once they get abnormal and they clump, they stick and they inhibit the synaptic vesicle exocytosis. So what would happen here? You would have toxic accumulation of dopamine vesicle and the terminal of the dopaminergic neurons, right? What else? This protofibril synuclein, they cause holes and pores into synaptic vesicles, which leads to release of the dopamine into the cytoplasm. And that's toxic, right? Because dopamine is toxic in the cytoplasm because it auto-oxidizes and they become oxidized dopamine, and oxidized dopamine is a free radical generate free radicals that will disrupt the homeostasis of the redox potential that leads to activation of apoptotic genes, cell death, and degeneration. In addition to that, the oxidized dopamine, we call it dopamine phenones, they cyclize and they become aminochrome. Aminochrome is their free radical generator. They generate free radicals, and they start adapting combining with lipids and protein, including the synuclein, and they form a toxic waste. It's called neuromelanin. Neuromelanin, along with protofibril synuclein, both, when the cells dies and degenerate, they will be released. Right? Who's going to take them? The microglia. The microglia, when they take them, they get irritated, inflamed, and they become what? Inflamed microglia, which is neuroinflammation, right? And the microglia, when they are active, inflamed, they start releasing the proto-inflammatory cytokines, the free radical, the reactive oxygen nitrogen species, and the reactive nitrogen species blocks the dopamine synthesis from the tyrosine, which is the tyrosine hydroxylase. They block that enzyme. So it inhibits the dopamine synthesis, right? The peroxynitrate, the other side of the nitric oxide, right? And so the other things about protofibril or synuclein, they act like prion-like protein. You know the prion-like proteins and those proteins misfolded, right? This alpha-synuclein, the mutated one, they be released outside these dopaminergic neurons by exocytosis and will be picked up by the neighborhood cells and goes by endocytosis and trigger the aggregations in the neighbor dopaminergic neurons, right? The same like prion proteins, right? And it goes or trigger the apoptosis and death to the neighbor dopaminergic neurons. What else? This protofibril alpha-synuclein aggregates of this mutated synuclein, they attack the mitochondria. They inhibit the complex 1, causing mitochondrial dysfunction. And when you have mitochondrial dysfunction, what will happen in mitochondria? They start leaking the free radical, the pathological free radicals. What would happen if you release the pathological free radicals from the mitochondria? It can cause release of the iron from the heme and non-heme proteins. Iron is toxic when it's being released. They are free radical generators. They can convert the hydrogen peroxide, the superoxide anions, to more powerful free radicals, which is superoxide radicals. And superoxide radicals trigger the apoptosis, the degeneration, and the cell death. What else? Well, those free radicals being generated or released from mitochondrial dysfunction, they can also cause opening of calcium channels from the endoplasmic reticulum through a certain type of calcium channels called L-type calcium channel, right? And they cause release of calcium. Calcium in cytoplasm in high concentration is toxic. It can toxicate the mitochondria far there. And when you toxicate the mitochondria, you end up with mitochondrial dysfunction, you start releasing what? Those pathological free radicals. In fact, toxic calcium can also cause membrane or mitochondrial membrane permeability transition, which leads to release of cytochrome oxidase itself, a combination of cytochrome oxidase, calcium, right, and including all the free radicals, they will induce the apoptosis, degeneration, and the cell death. So, when we are going to manage Parkinson's disease, is it enough to just give L-DOPA? No. You need to give iron chelation therapy to remove all this excess of the iron, right? Because they are free radical generators. So you can give
calcium chelation.
You need to give calcium chelations, whether it is pharmaceutical or natural. The natural one is Riservator. For the iron, we can use curcumin, but you can use the chemical one, the dysferoxamine, the pharmaceutical one, whatever you choose, but it's not enough just to give L-DOPA. Also, you may need to give reduced glutathione, IV, right, which helps to scavengers the free radicals. I think Dr. David Perlmutter, he has very great success. I don't know if you know him, he's in Florida, he's a neurologist, doing IV glutathione. I have a video of him, I met him in A4N, I want to invite him to be part of our work. And he gave me the permission to show his video, and I saw his video is very great, with great success using IV glutathione. But the problem is that it's not enough to give IV glutathione. You cannot manage oxidative stress by one therapy, by antioxidant monotherapy. Yes?
Have you used nasal spray glutathione?
Yes, that's what the thing that you can do by the compounding pharmacy, and I think we have a compounding pharmacy here who's listening and who wants to be creative, and he can do the IV glutathione, intranasal nano glutathione, intranasal dopamine, which is better than oral. The reason because oral, the absorption is not that perfect. You don't get a steady concentration. You get the off and on. So now they are technology where they're using an intranasal nanodopa or topical patch of dopamine, which is better, so you can get the steady concentration. So does that mean we're not giving L-dopa anymore? We just empower the antioxidant capacity? No, because you have almost 50-70% of nerves being degenerated. You still need to give them some sort of dopa to help them to produce those dopamine. Although the dopamine that they produce, it's toxic for them because they have a problem of recycling their own waste, the free radicals, right? That's the problem with those dopaminergic neurons. They already have waste of free radicals, and you're adding dopamine, it can toxicate more and more. And yes, when you give L-dopa, it will accelerate the degenerations, according to the lab studies and animal studies. But they did the human studies, and they find out there's no really change in the progression of the disease if you give the L-dopa early or late, and the reason why. If you don't give L-dopa, then you'll be stressing those dopaminergic neurons to make the dopamine out of scratch, which is tyrosine, and that is an active metabolic process, require ATPs, and also it generates free radicals. So if you give dopamine, it catabolizes, it gives you the free radical, it accelerates degenerations. If you don't give, you're stressing the dopaminergic neurons, and they still produce the free radicals out of the tyrosine. So what we need to do, we need to empower the antioxidant capacity of the cells and the removal of the waste by all methods, including everything that can help to patch those free radicals. And just 1 second, let me just give you an example here. I have a flat tire, and I want to use an example just to show you how the free radicals can be managed. Flat tire has many holes, well, three holes. And when I took it to the car shop, he has a liquid spray soap, and he starts spraying in it and finding all those holes, and then he starts patching it. If he patched one hole, it will not be fixed. He has to patch them all. In managing any oxidative stress, we know that our body have many sources of leakage of the free radicals, including the gut leaky syndrome, including toxins, including the mitochondrial dysfunction, including abnormal metabolism of drugs that you're taking, right? Maybe taking drugs and they become what? Free radical generative, like statins, including abnormal metabolism of nutrition, like folic acid, right? That's your area. I'm getting into there. And so there is many sources of this, and all of them has to be managed. So giving IV glutathione may help. You can see the video, it's dramatic improvement. But you're not getting the long-lasting effect. Even light therapy, if you give it, it may help the mitochondrial dysfunction, but that's not enough. You really need to work on all the leakage of the free radicals, including the cognitive therapy. If the patient is stressed and the sympathetic is fired up, then that generates free radicals as well, and that can aggravate the whole conditions. So we need to work on antioxidants, polyphenols, phenols, nitric oxide, coenzyme to stabilize the mitochondrial membrane, calorie restriction diet, right? We just talked about it, right? Exercise, photobiomodulations. Now, the big pharma, they know there's something about working on the slow of degeneration, so they create something called psilocybin. What is psilocybin? It's an inhibition of monoamine oxidase, monoamine oxidase inhibitors. That's B. That's in the microglia, which is responsible to degrade the dopamine, right? And so when it degrades dopamine, toxic dopamine, it generates the free radicals. So the big pharma say, let me go ahead and inhibit that. That will increase the dopamine bioavailability and decrease the free radicals. But according to the study, it's called Datacog, it did not show any improvement in the general progression of the Parkinson's disease. Why? Because it's monotherapy antioxidant. It will not work. Like any other antioxidant therapy, like therapy, if you do it by itself, it's not going to be as effective as you are doing all the antioxidant therapies. I think that Dr. Stephen did mention about all this multi-therapy antioxidants therapies, managing the gut syndrome. Still, you can do testing for allergy as well, because it can be source of free radicals allergy, so desensitize the patients. Nutritional genetics, folic acid, abnormal metabolism lead to increase in homocysteine. Homocysteine is a free radical generator, so it needs to be fixed. Pharmacogenetics, if you're taking drugs, you need to make sure it's metabolized well in the body, otherwise if it's generating free radicals, it aggravate the condition, like statin. Toxin screening, yeah, you need to toxin, screen them, detoxify them. 6 hormones, right, Dr. Gersh? 6 hormones is very important to restore the nitroredox balance because they are stimulating the epigenetic of antioxidant and anti-inflammatory. Vitamin D is very important, stimulate the antioxidant epigenetics. And how we can know that we are in the right track, right? We need to have some oxidative stress markers, which I think Dr. Steve Willard did mention about them. Add to it the ANS test, well, it's a reflection, any imbalance in ANS is a reflection of nitroredoxin balance, right? And the theta function test is another way of monitoring the efficacy of your treatment, knowing whether you're on the right track or not. The oxidative stress markers in the urine, which is the hydroxynonal, hydroxyguanosine, oxidized LDL, all of this needs to be used to monitor the efficacy of the treatment. Now, what's your question? I don't want to lose the track.
Do you use phosphatidylcholine to stabilize membranes, or?
Well, whatever you think that will help to empower the antioxidant capacity and empower the recycling of the waste, give it to the patients. All the testing that Dr. Steve Willard is doing, it's actually, it may look complicated. Other doctors will say it's accessory and extra, luxury. No, it is not. Because any deficiency can affect the all of humanity. So you need to go through all the things that Dr. Stephen Willard is actually practicing and is actually educating us to do it, because it will help ultimately to restore the nitroredox and manage those oxidative stress related disease, including iron chelations, calcium blockers. You can use the resveratrol, curcumin. You can use it for iron chelation therapy. Do I have time? Is it still?
Yeah, about 2 minutes.
2 minutes, okay. We can just go here and then we get the questions. So Parkinson diagnosed and management is diagnosed clinically by the trap, you know, the trap, tremor, rigidity, akinesia, postural instability. That's one of the ways to monitor the effects of treatment clinically, or you can use those oxidative stress markers. Management, main treatment, silagilin, pramipixole, right? But as we know, the silagilin does have antioxidant, but it did not affect the whole process of the disease or progression of disease because it is antioxidant monotherapy. The big pharma, they try, but they fail, and they say, oh, we failed, right? But I think if you follow the protocol of Dr. Steve Willard, I think you'll be able to restore the nitroredox balance. Pramipixole, it's a dopamine agonist, and it's also antioxidant, but still did not show any effect in the progression of the disease. The other thing is very important, restoring the nitroredox balance and neutralizing the free radical generators to slow the progression of the cholinergic neurons, degenerations, and increase the dopamine bioavailability at the substantia nigra. Now, do you remember when I say up to 70 to 60% of degeneration has to happen to manifest Parkinson's disease? So why we don't genetically test all the people who has a family history of Parkinson's disease, and if they have any genetic or any indication, why we don't start doing what Dr. Steve Willard is doing in his clinic and restore the nitroredox balance and give them polyphenols, especially the curcumin. Why? Because curcumin is the only supplement that looks like Congo dye. You know Congo dye they use for staining amyloid deposit and acetylcholine. They look like them. They actually tag the acetylcholine protofibrils and detoxify them. So if we start giving curcumin in the beginning, we may able to delay the onset of Alzheimer's disease and all kinds of degenerative disease, especially if they are going to tag and detoxify the protofibrils, acetylcholine, and also the amyloid fibrils. And other polyphenols does inhibit the formation of the aggregates, acetylcholine aggregates. Yes, all the ECGC, the coffee bean extract, all others, they definitely help to inhibit the aggregation. But what attach and tag and detoxify the aggregation itself is the curcumin among all its polyphenols. So that's why I consider curcumin as the king of the polyphenols.
I
Any
thought that
questions?
was the extract of cinnamon.
I think all of them does inhibit possibly the aggravation, but when it aggravates, the only thing that I know works, according to the publications, is curcumin.
Curcumin is an extract of the cinnamon.
It's extract of the turmeric.
Huh?
Turmeric. I don't know about cinnamon.
Turmeric?
Turmeric, yes.
Oh, okay, I know what it is.
Right. Okay, I think it's a
All
time.
Mediterranean food.
Do you have any questions?
Huh?
Okay, all of this is recorded and it's online. The other thing that I want to add, if the patient has pain from the spasm of the Parkinson's disease, or you have any pain conditions, I think the pharmacy I have here, it developed very unique nitro-compounding formulations to manage pain without that much of pharmaceutical ingredient with a great effect. And again, my video records of all my presentations is recorded on the website, including Dr. Burt. It's going to be on the website as well. Nitromedicine.com. Thank you very much.
We're going to take a break now.